Hi everyone, I'm Dr. Ramesh Venkatraman, Senior Consultant in the Department of Critical Care Medicine, Apollo Hospitals, Chennai. Today I'm going to be talking about the pharmacokinetic and pharmacodynamic principles that dictate the antibiotic use. Let's just take simple pharmacokinetic and pharmacodynamic parameters and look at how hydrophilic and lipophilic drugs, antibiotics particularly, behave in this situation. Let's take the left column first, hydrophilic antibiotics. We know that there is more water during sepsis in critical illness because of fluid overload, because of capillary leak, and therefore our volume of distribution can change. If it is a predominantly hydrophilic drug, it stays where the water is, which will be predominantly intravascular compartment. Therefore, at baseline, the volume of distribution would be low, but there is a potential for the volume of distribution to be increased because of sepsis-induced capillary permeability increases or fluid overload. Hydrophilic drugs are predominantly cleared by the kidney, and these are the drugs that I would worry about in terms of augmented renal clearance. Because they are hydrophilic, they do not attach to fat as easily, therefore they do not penetrate the cells that easily. In sepsis, my volume of distribution would go up. My clearance can either go up or come down depending on my end organ dysfunction and whether I have augmented renal clearance. The classic examples of hydrophilic drugs would be beta-lactam antibiotics like penicillin, cephalosporins, and carbapenems. We need to be careful about them. Aminoglycosides, glycopeptides, linezolid, and colistin. So all these drugs which are renally excreted are hydrophilic, and they need adjustment of their doses based on renal function and the volume of distribution of that disease state. What about lipophilic drugs? Lipophilic drugs in general have better tissue penetration because they can attach to the fat. Therefore, their volume of distribution will be high. A lot of drug from the plasma compartment will diffuse into the tissues, and therefore their volume of distribution will be very, very high. Since their volume of distribution is very high and they are lipophilic, they may not be very well cleared by the kidney, and most of them are either excreted or metabolized by the liver. They have excellent intracellular penetration. So if you have an intracellular organism that you're targeting, lipophilic antibiotic would be better than hydrophilic antibiotic. In cases of sepsis, since capillary leak or fluid overload does not alter the amount of fat in the body in general, their volume of distribution relatively remains unchanged even in patients with sepsis, and therefore our loading dose does not need to be changed for this reasons. Like any other disease pathology, the clearance can increase or decrease depending on the disease pathology and the end organ dysfunction, and that needs to be taken into account in terms of the maintenance doses. Classic examples of lipophilic medications include fluoroquinolones, macrolides, lincosamides, and TG-cycline. So it's a crude way of looking at how drugs behave inside the body. Hydrophilic volume of distribution will change with disease pathology. Predominantly renally excreted, you need to know that the common antibiotics are beta-lactams, aminoglycosides, linezolid, and colistin. Lipophilic, high volume of distribution to start with, predominantly metabolized by the liver or excreted by the liver. Their volume of distribution doesn't change over time with disease in general. Common antibiotics include fluoroquinolones, macrolides, and TG-cycline. So what happens in sepsis? In sepsis, I'm going to give you an antibiotic. I know that they have certain amount of volume of distribution and certain amount of clearance. If my volume of distribution is very, very high and my clearance is very low, then the concentration of the drug is going to be very, very high in the blood. On the other hand, if my volume of distribution is low, like a lipophilic drug, but my excretion is very, very high, then the volume of drug in the plasma compartment is going to be low. So it depends on the volume of distribution and clearance. My plasma concentration will vary depending on the antibiotic's properties in vivo. Understand that for any given patient, the bioavailability of the antibiotics is unpredictable. For example, let's say a patient with sepsis. He can have increased cardiac output, he can have leaky capillaries and altered protein binding, he could be perfectly normal, or he could have significant liver and renal dysfunction. All this is going to act in different ways. Increased cardiac output is going to make you increase renal blood flow, therefore increase clearance of the drug. Leaky capillaries will decrease the volume of distribution, therefore decrease the plasma concentration. If nothing is changed, then the property of the drug remains the same. If there is end organ dysfunction, the clearance of the drug goes down, therefore the plasma concentration will go up. But in any given patient, a permutation combination of any of these things can happen, therefore it's extremely difficult for anybody to predict what the plasma concentration is going to be for that patient for that particular day. For certain drugs, we routinely measure the plasma levels so that we do not cause toxicity. At the same time, we also make sure they are within the therapeutic range. For example, aminoglycosides or vancomycin. Let's move on from pharmacokinetics to pharmacodynamic principles. The most commonly talked about pharmacodynamic principle would be minimal inhibitory concentration. What is the minimal inhibitory concentration? As the slide suggests, it's the minimum concentration of an antibiotic that inhibits visible growth in the broth culture. Meaning, what is the least amount of antibiotic that will inhibit any growth in the culture plate? It describes the relationship between the antimicrobial drug and the physiological activity. It kind of gives a surrogate idea for us to say, okay, this drug in very little concentration itself causes inhibition, which means it's very, very effective. Or need a lot of drug to inhibit the growth, that means that this drug may be ineffective against that particular bacteria. So it kind of gives us a surrogate idea of how the drug is going to be effective inside the body. It is a quantitative measure of drug activity against that pathogen in vivo. However, it has got several problems. Even though we commonly use MIC of antibiotics, we need to understand it's got several problems. First and foremost, it's a static measure. What do I mean by static measure? When I'm outside the body in a culture plate, my concentration of antibiotic remains constant. However, in the human body, the concentration of the antibiotic is not constant. As I give you a medication, the medication is going to be metabolized, excreted, and moved from the intravascular space to outside. Therefore, the concentration of the drug would be variable, and by then I will also give a second maintenance dose. So there are ups and downs in the concentration which are not mimicked by the MIC technique that we normally see. It only measures growth inhibition. It does not tell you whether the growth is completely zero or not. For example, I can grow and inhibit at the same rate so that the net growth can be zero. This can happen in a culture plate, but it is not possible in vivo. It only quantifies the net growth rate within the observation period, which is 18 to 24 hours is what the cultures are observed before MIC is reported. So all we know is for that 18 to 24 hour period, this is the relationship between the drug concentration and the growth, which may not be true in vivo. Finally, we need to understand something called post-antibiotic effect. There are certain antibiotics that exhibit this phenomenon called post-antibiotic effect. The commonest being aminoglycosides. Any antibiotic that decreases protein synthesis will exhibit post-antibiotic effect. Why is that? If I inhibit my protein synthesis, the bacteria has to take more time to regenerate those proteins, and therefore even after I stop my antibiotic, the effect of inhibition on that bacteria lasts longer because the bacteria has to take time to regenerate the proteins, and all those time it cannot grow. Therefore, my benefit of antibiotics lasts longer even after the dose completes. The classic example of post-antibiotic effect is aminoglycosides. Next, we are going to talk about certain important concepts. I am going to give a drug. The drug concentration goes up over a period of time and then slowly comes back and goes back to zero once the drug is completely cleared. The peak concentration will depend on the dose I give and the volume of distribution. Time taken to come back to zero will be determined by my clearance of that particular drug. In vitro data to say what MIC is, we know what the minimal inhibitory concentration is. Obviously, when the drug level goes up, it is going to go above the MIC. There are certain drugs that are concentration dependent. What do I mean by concentration dependent? If the concentration of the drug is much higher than the MIC, then they are very effective. The fundamental property that determines their efficacy is the concentration over the MIC. and they are called as concentration dependent drugs. We say Cmax over MIC. Cmax is the maximum concentration. We know what MIC is. The maximum concentration above MIC will determine the efficacy of the drug. The classic example of this phenomenon is aminoglycosides. There are certain antibiotics that do not act by concentration dependent mechanism, meaning as long as you have reached the MIC, it doesn't matter whether you have reached 2 times the MIC, 4 times the MIC or 8 times the MIC. What matters is how long you stay above the MIC. This is what we would call as time above the MIC. The longer you stay above the MIC, certain antibiotics are more effective. These are called time dependent antibiotics, the classic examples of which is beta-lactam antibiotics. The last is, it doesn't matter what the concentration is, doesn't matter what the time is, it integrates both, and we call it area under the curve. The entire curve area above the MIC is what determines the antibiotic effects. The classic example is fluoroquinolone. So, just to give you a physiological application of these 3 principles, aminoglycosides are unique. They have concentration dependent MIC, they have significant post antibiotic effect, which means if I give one dose, high dose, my concentration will be very high above MIC, so my efficacy will be very good. Even after the concentration drops down, they exhibit some post-antibiotic effect, so there is no need for me to top up by giving a second dose. It makes perfect sense for me to give one dose and wait, one large dose, single daily dose and wait and maximize my efficacy. The other half of the advantage is the renal mechanisms that are necessary for the toxicity of aminoglycosides are saturable, meaning if I give you a large dose, once the mechanism is saturated, it doesn't matter whether I have more drug or not, only certain amount can go and get into the kidney. So, by using a single daily dosing, I am taking advantage of the pharmacokinetics by improving my concentration above MIC, by utilizing my post-antibiotic effect. At the same time, I am minimizing my nephrotoxicity because that mechanism gets saturated once the drug concentration reaches a certain time. In time-dependent antibiotics like carbapenems, I told you the principle or the main factor that determines your efficacy is going to be time above the MIC. So, the more time the drug remains above the MIC, the efficacy is going to be more. How do I make sure? I make sure by giving more frequent infusions or giving the infusion over a prolonged period of time, so that during the entire infusion period, my concentration remains above the MIC. So, carbapenems are classically infused over 3 to 4 hours. The general rule is the infusion time should be 40 to 50% of the dosing interval, which means that if you are going to give an 8-hourly dosing, the infusion period should be at least 3 to 4 hours. Therefore, the time above MIC is consistently high enough for us to get maximum efficacy. I've already discussed these things in the previous slide and given you the rationale for utilizing these principles in bedside use. We also need to look at the drug stability. If a drug is not too stable, then we cannot be giving continuous infusions or prolonged infusions. Generally, certain cephalosporins and carbapenems are the only drugs that have been given as prolonged infusion of 3 to 4 hours, and the efficacy seems to be much better than quick bolus doses. What are the other considerations I need to have when I give antibiotic to the patients? We need to understand that it is not only the plasma concentration of the antibiotics that matters, it is also the concentration of the antibiotic in the particular site where I want the concentration to be high. If we take an example of an abscess, the pH inside the abscess is acidic. Some of the drugs can get deactivated because of the pH. There is already a lot of bacterial DNA which can actually deactivate the antibiotic, and it is a kind of an anaerobic area where the bacteria may not grow as fast. Therefore, any drug that acts on the growth of bacteria like a beta-lactam may not be very effective if given alone. Special infections. If we have a pancreatitis, then carbapenems will penetrate the pancreas the most. You have to understand that drugs like daptomycin are inactivated by the surfactant in the lung, therefore should not be used for a pneumonia. Tigecycline is a drug which reaches very minimal concentrations in the urine, therefore no point in using tigecycline for gram-negative urosepsis. Tigecycline also stays in the blood for a very short time, and most of the time the concentration is actually higher in the tissues, therefore it's not an ideal drug to use in bacteremic patients. Meningitis is unique. Most hydrophilic drugs, including beta-lactams, will not enter the CSF regularly. Lipophilic drugs, on the other hand, will enter CSF a lot more easily. However, in a patient with meningitis, the blood-brain barrier is disrupted and the hydrophilic drugs are also able to enter the CSF and have good protective effect. Understand that in meningococcal meningitis or pneumococcal meningitis, when we use steroids in bacterial meningitis, the permeability of the drug can be hindered by the steroids that we give, and that needs to be balanced. So far we have talked about the effect of antibiotic on killing the bacteria. However, we understand that antibiotics also induce resistance. If I give you an antibiotic for a long period of time, it destroys the loss of bacteria, but then the other bacteria start growing up and you get a resistance strain over a period of time. For me to prevent it, I need to achieve much higher concentrations, and those are called mutant prevention concentrations, MPC, not MIC. These are concentrations high enough so that they prevent any mutant to be developed and therefore minimize resistance. A lot of work is being done in this MPC. At this point of time, we don't have all the data to understand and use it at bedside, but understand that the MPC concentration should be much higher than the MIC that we use. In summary, if I put it all together, if I have an infected patient, I need to have my pharmacokinetic considerations in terms of volume of distribution, which would relate to the solubility of the drug, hydrophilic or lipophilic, protein binding, and the clearance mechanism. Based on my volume of distribution, I will determine my loading dose, my clearance will determine the maintenance dose. Then I need to think of clinical reasons. What is the site of infection? Will my antibiotic penetrate that? Is it easy to get into the site? Does that site have adequate vascular supply? What is the severity of illness? How hard do I need to hit the illness with antibiotics? What is the body composition? What are the likely pathogens? Is there a chance of resistance in those bugs that I need to use a different antibiotic? Then I need to think of the pharmacodynamic considerations, which would be whether it is a time-dependent drug, concentration-dependent drug, area under the curve drug. Does this drug have a post-antibiotic effect or not? And all those factors have to be incorporated in my decision-making of the choice of antibiotic, the dosing, and the maintenance schedule. In conclusion, PK/PD factors determine the efficacy of antibiotics in critically ill patients. The interactions are very complex. It's extremely difficult for us to predict how a drug is going to behave in vivo. If possible, drug concentrations need to be measured, but we do not have the ability to measure the drug concentration for a lot of drugs. When possible, utilize them to make your clinical judgments. Understand that in vitro MIC does not mirror in vivo efficacy because of all the limitations I have explained earlier. We need to understand the PK/PD principles and apply them optimally so that the antibiotic's efficacy is maximized. We need to understand the concepts of volume of distribution for giving the loading dose, the clearance mechanisms for adjusting the maintenance dose. We need to understand whether the drug is concentration dependent or time dependent and decide on the maintenance regime, and the post-antibiotic effect may have a role in terms of determining the dosing frequency of that particular drug. With that, I want to thank you all for the patient listening, and I would like to conclude my talk here. Thank you.